have seats up front, so if anyone would like to get a seat, please come forward.
Thank you, Dorothea, dear colleagues. So moving on from the question, can you do better in MIVOS, to the question, can you do better in LVO? It's my great pleasure on behalf of the MARRS investigators to present our trial. Here is our disclaimers and disclosures. So the soul of the millipede catheters is this corrugated technology that delivers enhanced flexibility and anti-kicking properties. Okay, so you typically in this trial deliver the millipede 88 over the millipede 70 without the help of a navigation system. The MARRS was a multi-center, international, prospective, open-label, single-arm trial. This was conducted at several centers in US and Europe. Adult patients with NIH stroke scale equal greater than 6, aspects equal greater than 6, or PC aspects equal greater than 8 within 8 hours, who had occlusions of the intracranial ICA, the M1, M2, or vertebral-basilar arteries were treated in this trial. The maximum diameter for the millipede 88 was 2.7 millimeters, and for the millipede 070 was 2.2 millimeters. The typical exclusion criteria and oversight applied to this trial. The primary endpoint was the rate of successful reperfusion modified TK2B or greater within 3 passes with the device without any additional therapy. In terms of the safety outcome, we had a comprehensive review of our adverse events as required by the FDA. We enrolled a total of 237 patients. They were consented. Out of these, 57 patients were screen failures, leaving out 180 patients that were treated with the system. Out of these, 7 patients had multiple occlusions, so the FP metric doesn't apply. Another 6 patients had either ICAD or dissection, which compromised the deliverability of the system. Extracranial occlusions in 3 patients, and 3 patients had very low aspects, 2 or 3. Leaving out 162 patients in our per protocol population. Out of these, the 88 system was using a total of 101 patients, one of the largest 88 cohorts to date. And then you have our cohort of special interest, which is the M1 occlusions treated with the 88 catheters. Demographics, the median age was 69, the median NIH stroke scale was 17, median aspects was 9. About 55% of the patients received intravenous thrombolytics. Clot location, it stands out that 1 in 4 patients had intracranial ICA occlusion. This is about 2 times higher than what was seen in some of the other recent similar trials. And here is our first endpoint of interest, or primary endpoint. You achieve successful reperfusion with the millipede system only within 3 passes in over 90% of the cases. FP rate was 57% in the per protocol for the overall cohort, and 61% when you look at millipede 88 specifically, for the first time crossing 60% in a prospective study. But then we know that the key to contact aspiration is to optimize the catheter to vessel ratio, right? So can we do better specifically with a bigger catheter in NM1 occlusion? This actually comes from our early clinical data and preclinical data, where you knew that this catheter will provide better M1 recanalization than ICA recanalization. So we specifically wanted to look at that cohort of interest. And it was amazing that you achieved full reperfusion, TK2C or 3, in 77% of the cases. So for the first time, you were approaching 80% recanalization, as was actually demonstrated in the bench data by Matt Gunis at UMass, that with a larger cross-section catheter, you could potentially achieve such high numbers. Safety was quite spectacular. Symptomatic intracranial hemorrhage rates in the 1 to 2% rate, perforation, 0 cases, and about 1% dissections. In terms of good outcomes, approaching 60% in the per protocol population with less than 12% 90-day mortality rate. The number of passes had a median of just 1, and I really want to call out to 99% target achievement. You navigate this catheter 99% of the time with the use of navigation catheters in less than 13% of the time. There is now it's called the zip line navigation catheter from Perfuze. That system was not available during this trial. So this is essentially taking the 88 over the 71 in the vast majority of the cases. And here is the summary. We now have 3 megaboard trials demonstrate this is very safe. Our trials have given us about 1 to 2% symptomatic intracranial hemorrhage rate. What you see here with the millipede specifically is a very high navigation to target of the overall system, and including the 88, over 95% target navigation with the 88. And finally, something you have never seen before. This is by far the highest rate of full reperfusion clot ingestion to date, 61% in the overall cohort and 77% in the M1. With that, I would like to acknowledge the contribution of our investigators and say a big thank you to our patients and family. Thank you very much.
Next, Dr. Jankovic is going to present an update on the sacral